Our next speaker is Dr. Sudhir Kumar. He is talking on a step-by-step external DCR. Sir.
And good afternoon, everybody. And thank you, AIOC. Thank you, Ravi Ranjan.
Yeah.
As we have discussed about the nasolacrimal duct block, and the treatment is still DCR, either external or internal. And there are many variations in the external DCR. But before that, we must see that the basic surgery, which is much needed, and we must do several external DCR with conventional methods, so that you can always improvise upon that. So the functional goal is, as usual, relieving the symptoms of epiphora, discharge, and recurrent inflammation. And this is achieved by achieving anatomical goal, which is nothing but creating a bypass of blocked NLD by making a fistula between lacrimal sac and nasal cavity. And this is achieved by making a large bony ostium. This is one of the most important things. And having a mucocele lined anastomosis, then it becomes fistula. So as we have discussed, indications are primary and secondary nasolacrimal duct obstruction, and congenital nasolacrimal duct obstruction not responding to probing, or when it is associated with mucocele. So before we go into the DCR is notorious for hemorrhage. So, and before we do, there are many chances that we may misdiagnose the case of epiphora as NLD blocked. So first confirm the diagnosis of nasolacrimal duct, and the simplest method is positive Rhoplast. This is just you press over the medial canthus, there will be regurgitation. And you can confirm it through nasolacrimal duct syringing, or if you find something abnormal, or you find some mass there, you can always go for DCG, and DCG means dacryocystography, and it's a very simple X-ray method, and this can also be done in repeat surgeries. And apart from that, since it is just notorious for hemorrhage, so hemoglobin and blood grouping should be done, BTCT, and control of hypertension and diabetes as in any other surgery, and any other GA requirements if it is to be done under GA. So most of the time it is done under LA, especially in adults. But some cases are contraindicated for DCR, because if you suspect malignancy, it's absolute contraindication, malignancy of the sac, nasal cavity, etc. In atrophic rhinitis, there is atrophy of the mucous membrane, nasal mucosa, and so the patients might present with foul smelling, but he will be having anosmia. At the same time, dry eye, and if you do DCR, then you are making the patient at some disadvantage, because he needs more tear. So, and in any bleeding disorders, tuberculosis, rhinosporidiosis, and even in old age, you can go for simply DC. You can go for dacryocystectomy rather than DCR. So the patient is prepared. Control of blood pressure. Stop any blood thinners if he is taking. Nasal packing. Do the nasal packing soaked in xylomethazolone or xylocaine and epinephrine. And before we go into the details, as we have discussed here, the anatomy, this is this lacrimal fossa, and this is anterior lacrimal crest, and this is posterior lacrimal crest. In between this, the sac lies. Under the skin, there is orbicularis muscle, which makes medial palpebral ligament or canthal ligament, and the medial canthal ligament has two crusts which wraps around anteriorly and posteriorly over the sac. And as far as we should not try to disturb this structure during the surgery, And if it is cut during this surgery, for better exposure to the sac, it should be repositioned as where it is. So this is nothing but DCR is nothing but making a fistula between the sac and the nasal cavity in the medial antrum. And without going into the details of the names, various names of the nerves, you have to block inferior to the sac. This will block the inferior orbital nerve, and you inject sufficient bupivacaine and xylocaine mix here. And similarly, superior orbital nerve can be blocked through this here and this place. And that is in between the near the anterior medial 1/3, at the junction of medial 1/3 and lateral 2/3. And another block should be injection should be given anterior to the sac, and then it is inserted. The needle is inserted deeper so that it can block further deep inside and same can be repeated from the posterior side of the, or rather lateral side of the sac itself. So this should be done around 10 minutes before you have planned for surgery. That will give sufficient anesthesia and hemostasis, because most of the time we use xylocaine with adrenaline. So these are the positions we have discussed. So incision making is very simple. There is two school of thought, but most of the time 3 to 4 millimeter incision can be made 3 to 4 millimeter medial from the medial canthus, and because the angular vein lies around 7 to 8 millimeter medial to the medial canthus. So this is the most popular incision, where you trace the anterior lacrimal crest, and this goes above till the medial canthal ligament. And then blunt dissection is carried out to reach the periosteum, and periosteum elevator is used to separate the periosteum from bone and reflect it laterally. And after retracting this, the lacrimal fossa is exposed, and then lacrimal bone is thinner bone which is punctured, and then it is extended anteriorly, superiorly up to the ligament, and then inferiorly to the nasolacrimal duct junction. That is most important. Otherwise, this may fail. And around it comes around 1 finger can be put into the hole, and then both the sac is nasal sac, mucosal sac, and lacrimal sac is exposed here, and you can easily identify these structures and cut the lacrimal sac in this fashion, and you can give you can augment this in anesthesia with further giving injection, and then this can be cut, and excess part can be removed, and then sutured tightly and anchored to the structure. There are intraoperative complications.
Sir, complication will be dealt separately.
It has been okay, and with this I say thank you.
Okay, thank you.